So I'm going to talk about the Jewish Woman's Guide to Genetics of Breast and Ovarian Cancer. And I'm going to be talking a lot about hereditary cancer. So I really want to make the point that most cancers are not hereditary. And in general, I would say about 85 to 90% of breast cancer is not hereditary, and about 80% of ovarian cancer is not hereditary. So, and in general, we say that about 10% of malignancies are caused by an inherited predisposition. But there is a unique situation with, with the risk for breast and ovarian cancer in Jewish women. And I'm going to talk mainly about two genes, BRCA1 and BRCA2 genes. They're still the main genes in which mutations cause an increased risk for breast cancer. They were discovered in the mid-1990s. And the way they are inherited is a way that's called autosomal dominant inheritance. Each of us, for each gene in our body, we have two copies, one from our mother and one from our father. So here you can see the mother has two copies, and she can pass on to her children either one of her pink copies, which are both normal. And you see the father here, he has two copies marked in blue, and one of the copies has a mutation in it. And when he fathers children, he can either pass on, he can either pass on his normal blue copy. These children are not going to inherit the mutation, or he can pass on the copy with the mutation, in which case these children do have the mutation. So you can see it's a 50-50 chance of getting the mutation or not getting it. And I had the father carry the mutation here on purpose because it's important to realize that the BRCA1 and BRCA2 mutations can be inherited from the father just as well as from the mother. And I know that often people think only about their maternal family history of breast and ovarian cancer, but they should be equally concerned about their paternal family history. So what's special about Ashkenazi Jews? So it turns out that there are three different mutations, two in BRCA1 and one in BRCA2, that are particularly common in Ashkenazi Jews. And altogether, if you look at all of them combined, about 1 in 40 Ashkenazi Jewish women and men carry one of these mutations.
Is it frozen?
Yeah.
Yeah. It's frozen. Sorry. Oh, there she is. Hi, sorry, it got frozen.
Okay, so hopefully I'm back now.
Yeah.
Okay, sorry. So what percentage of breast and ovarian cancer in Ashkenazi Jews are explained by the common BRCA1 and BRCA2 mutations? So it's about 40% of all ovarian cancer cases and about 11% of all of breast cancer cases. So that's a significant percentage. And if you think about it, it's an opportunity for prevention, because if we figure out how to prevent these cancers in these carriers, we would be reducing ovarian cancer by 40% and breast cancer by about 11%. And why do we want to identify carriers? So I just mentioned prevention, but also for treatment, because we know there are now specific drugs called PARP inhibitors that are effective specifically in women who have BRCA1 and BRCA2 mutations. So if you become affected, knowing that you have a mutation is very important for your treatment. And prevention, obviously, if we're talking about women who've never had cancer, it means to prevent cancer in the first place. But it's also important to remember that for a woman who's had breast cancer, it's important to prevent a subsequent ovarian cancer. And the other important factor is relatives. When you have a genetic test, it has implications not just for you, but also for your relatives. And you can prevent breast and ovarian cancer in them too if they know they're at risk and they can be tested. So what do we do when we identify a woman as a carrier? So really there's screening and surveillance. For breast cancer, it starts at age 25 to 30. Basically, it's a physical exam by a physician every 6 months, a mammography once a year from age 30, a breast MRI once a year, And these are spaced so that every 6 months you either have a mammography or an MRI. What about surveillance for ovarian cancer? Well, the truth is there is not effective surveillance for ovarian cancer, although some guidelines originally recommended vaginal ultrasound and a test of a tumor marker called CA-125 every 6 months. But we know that that's not really effective at detecting ovarian cancer early. And that's why the emphasis for ovarian cancer is actually on prevention rather than on early detection. So early detection is done, like, as I said, by mammography, which is basically a type of X-ray of the breast. You can see here what happens when you go in versus when you go out. And this is what would happen if women controlled the world. And then we also have breast MRI, which is much more sensitive and has now actually entered the mainstream in terms of women carriers. It has a much higher rate of detection of cancer than does mammography. What about prevention? So I put here a face I'm sure many of you recognize, which is Angelina Jolie. And in 2013, she came out and spoke about the BRCA1 mutation in her family. She is not Jewish. She has a specific mutation that's very different. Her mother died at age 56 of ovarian cancer. And she came out and told the world about first having a mutation, then having a double mastectomy, and then having her ovaries and fallopian tubes removed subsequently. So unfortunately, but still importantly, if we want to prevent cancer in carriers, it's still mainly surgical. Now, I know there's a lot of emphasis on mastectomy, but you should realize that most or many women who are carriers choose not to have mastectomy. What's actually really the more important surgery is having the ovaries and the fallopian tubes removed, usually around age 40, when childbearing has been completed. And the reason this is so important is because ovarian cancer is difficult to detect, and it has it's difficult to cure. And it's been shown that if women who are carriers have their ovaries removed in time, there's a 60% reduction in mortality in general. And it's very rare that anything preventive actually reduces total mortality. There's a 56% reduction in mortality from breast cancer and a 79% reduction in mortality from ovarian cancer. And this is surgery that's much more acceptable to women than mastectomy. I also want to emphasize, we did a study looking at what happens to women who decide not to have mastectomy. And as I said, this is the majority of carriers. So we've actually shown that knowing that you're a carrier before you develop breast cancer is really life-saving. What you can see in this graph here is women who started out as carriers. Some of them knew they all had breast cancer. The ones on the green line knew that they were carriers before they developed breast cancer. So they were tested while they were still unaffected. They knew they were carriers, and they had surveillance with mammography and MRI. And you can see that at 11 years out, 94% of them were still alive. On the other hand, the second group, which is the orange line, are women who only found out they were carriers after they were diagnosed with breast cancer. And if you look at those 11 years out, you see that unfortunately 22% of them had already died. So the reduction is actually an 80% reduction in mortality if you know that you are a carrier before you develop cancer, even if you choose not to have your breast removed. What happens with breast cancer is that the intense surveillance can help you detect the breast cancer early, and early breast cancer is completely treatable. Unfortunately, until today, in most countries, in most of the world, even among Jewish women, most of the testing for BRCA1 and BRCA2 mutations is only done after a woman has developed cancer. So this is a family pedigree. Circles are women and squares are men. And you can see here, sort of, these are siblings, and this is the older generation. So this woman, this is her father, this is her mother, this is her grandmother, this is her grandfather, and so forth. So this is a real 49-year-old woman who came to my clinic after she was diagnosed with ovarian cancer. She was tested for the common BRCA1 and BRCA2 mutations, and she has one of the BRCA1 mutations. But this was only discovered after she already had ovarian cancer. So if you want to think about it, it's really a missed opportunity for prevention if you only test a woman after she got cancer. And if we want to prevent cancer, we need to be testing unaffected women. The problem is that unaffected women are currently tested only if they have significant history in their family. And we know that from various studies that about 50% of carriers actually don't have a suggestive family history. And this has to do with various factors. I'm going to show what happened in this family. So this is a large family, and really there's no other relevant cases of cancer. But when we started testing the family, we found out that in fact, this woman inherited the mutation from her father. Her 93-year-old grandmother was still alive. We tested her and we found out she didn't have the mutation. So all of this large family here is really irrelevant. That's not where the mutation came from. The mutation came from her paternal grandfather. And you can see that in this part of the family, there were basically only men. And men can get breast cancer from BRCA mutations, but it's much rarer, and they generally don't become affected at all. So basically what happened here is you had a family with lots of males. The mutation was inherited from the male line, and this woman just didn't know she was at risk, even though she was a carrier, just because she had no family history. So we actually did a large study to figure out what's the natural history of mutations in Ashkenazi Jews in general, if we just go to the population level without family history. And we did this almost 8 years ago. And we tested over 8,000 Ashkenazi Jewish men, so they weren't selected on family history. And we identified 175 carriers among them, which is what we would have expected. And then in those families, we went and tested the women and found out if they had already cancer, if they didn't have cancer. And what we found out was that in these families that we identified in the general population, the breast cancer risk was about 60% for BRCA1 carriers, 40% for BRCA2 carriers. If we look at ovarian cancer, it was about a 50% risk of ovarian cancer for women in these families. Just to give you an idea, in the general population, the risk for ovarian cancer is slightly less than 2%. So we're talking about much, much higher risks. And the combined risk to get either breast or ovarian cancer was around 80%. So the risks are very high, even if you're just identified at the population level, even if you don't have family history. So in 2014, we were at the point where we said, well, you know, there's 1 in 40 Ashkenazi Jews has one of these mutations. They account for 10% of breast cancer, 40% of ovarian cancer. We have effective means of early detection and prevention, mainly removing the ovaries. And we have carriers at the population level that are at very high risk for breast or ovarian cancer, but we're not going to identify about 50% of them if we keep testing just based on family history. So we really thought that what we should be doing is offering this test to every Ashkenazi Jewish woman. There are big questions about how to do it. Do you really need a lot of genetic counseling? Is it enough to get written information? And we've done a lot of studies showing that you can receive fairly minimal written information ahead of the test. And the really important thing is actually to provide the information to carriers after they've been identified or to women with significant family history. So I originally wrote fast forward to 2020, but it took us 6 years to convince the Israeli health system that, so that's why I said a little slow, I wrote it but slow, that really this test should be offered to every Ashkenazi Jewish woman. So in January 2020, this was approved for inclusion by our national health system that provides all the health services through four HMOs, or what's known as Kupot Cholim. So, you know, January 2020 is kind of a fateful date because shortly thereafter, COVID-19 pandemic began. So our Ministry of Health had more pressing concerns. But I would say in the last half year or so, this has really taken off. And currently, at least about, I would say 6,000 women are being tested every month, and the numbers are growing, and we see more and more identification of women who are at higher risk. And, you know, hopefully this will have a major impact in the near future. I just want to mention, because Elizabeth Wurtzel is fairly well known in the United States. She's a Jewish author who wrote the book Prozac Nation, and she died a little over 2 years ago at age 52 of metastatic breast cancer. And about 5 years prior to that, in 2015, she wrote an opinion piece in the New York Times called The Breast Cancer Gene in Me. And I'm actually going to read what she wrote. She said, Jewish organizations have done too little about BRCA. Hadassah, one of the largest and oldest Jewish women's group, has supported research on BRCA, but so much for that. In April, its president, Marcy Nathan, released a statement entitled, "Testing is not for everyone." She said the test sounds simple enough, but understanding what to do with the results can be a complicated, gut-wrenching journey. And what Elizabeth Wurzel wrote in response to that statement by the Hadassah president was, yes, it can, but not nearly so much as cancer. And I think that's really, I think that's really the point. Yes, it is complicated to know you're at risk, but it's much more complicated to be a young woman discovering that she has breast or ovarian cancer. So, I think there's a lot of talk medically also, and I'm sure, lay people also hear about using genomics to guide therapy, the whole idea of personalized medicine, precision medicine, not one size fits all, but fitting the treatment to the precise person. And I say, why reach the point where you need treatment? Because, an ounce of prevention is worth a pound of cure. And to paraphrase Hillel, if not us, then who? And if not now, when? And I just want to thank the organizations that support my research, mainly the Breast Cancer Research Foundation, the Israel Cancer Association, and the Israel Cancer Research Fund, and a lot of physicians and genetic counselors and lab people throughout the years who have helped bring about these projects. And thank you for inviting me, and I'd be happy to take any questions.